there was sand and hills and rain. The first thing I met was a fly with a buzz and the sky with no clouds. The heat was hot and the ground was dry, but the air was full of sound. I've been through the desert on a horse with no name. It felt good to be out of the rain. In the desert, you can't remember your name, because there ain't no one for to give you no pain. La 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 After 2 days in the desert sun, my skin began to turn red. After 3 days in the desert fun, I was looking at a riverbed, and the story it told of a river that flowed made me sad to think it was dead. You see, I've been through the desert on a horse with no name. It felt good to be out of the rain. In the desert, you can't remember your name, 'cause there ain't no one for to give you no pain. La, 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 After 9 days, I let the horse run free, 'cause the desert had turned to sea. There were plants and birds and rocks and things. There was sand and hills and rings. The ocean is a desert with its life underground and the perfect disguise above. Under the cities lies a heart made of ground, but the humans will give no love. You see, I've been through the desert on a horse with no name. It felt good to be out of the rain. In the desert, you can't remember your name, 'cause there ain't no one for to give you no pain. La, 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 la. La, 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 la.
Hey, Dr. Antinori, just want to say congratulations on an amazing career, and a big thank you to everything that you've done for me. Personally, having you as a mentor, all the guidance you gave me through residency was just absolutely invaluable. I would not be here in Florida on this great career path if it wasn't for you, so many thanks. It was awesome getting to work with you, and a pleasure and an honor. But if you're ever, now that you're retired and want to come down and play golf, let me know. But again, thank you so much, Dr. Antinori, for everything you've done for me, and congratulations on such an amazing career.
Congratulations!
Congratulations on your retirement, Dr. Antinori. And by the way, this little one you met when she was in this one's belly. And then we have a new one here. This one's Luki and Hannah. Congratulations again, Charlie. Enjoy your retirement.
Hey Charlie, I just wanted to congratulate you on a successful career. Thank you for everything that you've taught me, and enjoy your retirement. You deserve it.
Way on down south, London town.
Guitar George, he knows all the chords. But it's strictly rhythm, he doesn't want to make it cry or sing. If then an old guitar is all he can afford, when he gets up under the lights to play his thing. And Harry doesn't mind if he doesn't make the scene. He's got a daytime job, he's doing alright. He can play the honky-tonk like anything, saving it up Friday night.
Welcome to Medically Speaking. This is Dr. Boris, and with us today is Dr. Charles Antinori. He's a vascular and general surgeon. And we're going to talk today about one of his big areas of expertise, that's peripheral vascular disease. Mm-hmm. And we're going to do some other shows in the future about some other areas of expertise he's bringing here to Burdett Tomlin Hospital. Mm-hmm. And I welcome you to Burdett, Charlie, and tell us about yourself, because you're not a rookie.
Yeah. Well, as you know, Mike, I've practiced general thoracic and cardiovascular surgery up in the Camden area, Cooper and Lady of Lourdes primarily, for actually the last 23 years. And I've been coming to Cape May since about 1989, and had a house here since 1995. So just recently, January, I moved down to live here full-time and practice full-time at Burdett Tomlin, doing general and vascular and thoracic, I guess.
Wonderful. And you're bringing us some expertise that we really didn't have before.
Hope so.
Well, I mean, a lot of people left the area for peripheral vascular disease and treatment and surgery, and now you're here and we can keep people locally.
It's interesting. It seems like it's so far. When I was talking to people coming down, they were telling me about how many elderly people there are in Cape May County that were leaving, and I have to say I didn't totally believe them. Right. But after a few months here, I believe it. Yeah.
And it was difficult because the population that we're going to be talking about today, a lot of times travel is difficult and getting out of the area is difficult. Right. And, this is going to be a much better situation for a lot of people. Mm-hmm. When we talk about peripheral vascular disease, though, what do we mean by that term?
Basically, in peripheral vascular disease, we're just talking about one of the most common conditions to mankind, hardening of the arteries. And in peripheral vascular disease, we're talking primarily about the arteries to the leg. It's the same condition really everywhere all over the body, in the heart, in the carotids, in the abdomen. But today I think we're going to focus on the legs. On the legs. And it's just, again, I call it a lot of times the final common pathway. I don't even, when it occurs in the 70s and 80s, I hate to even call it a disease because it's almost really just part of obsolescence to a certain extent. When you have problems in the 40s, 50s, and 60s, then I think it's a disease where the narrowings have come on much sooner than the general population. But sooner or later, if you don't get hit by a truck, and if you don't die from cancer or something like that, coronary artery disease or peripheral vascular disease is going to get you.
So my next question was, how common is it? Obviously, you're going to tell me that it's pretty darn common.
Very common. The more common, the older the population. The older section of the population that you look at. The estimates I was just looking at recently say that when you get up in the 60 to 70 age group and the 70 to 80 age group, it's probably a fourth or maybe more percentage of the people have clinically significant peripheral vascular disease.
And other than age, what other groups might have an increased incidence of peripheral vascular disease?
Well, obviously, it's the same group that we worry about in pretty much everything. Diabetics are obviously much more prone to peripheral vascular disease. People who smoke heavily, that's probably the single most preventable cause of accelerating peripheral vascular disease. Smoking, hypertensive patients, and the patients with high blood lipids. Same group that's at risk for heart disease, because in a sense, this is the same disease. Right. It's just different arteries that are getting affected.
So it's likely if one has the other, they're going to have, if one has heart disease, they're going to have peripheral vascular disease and vice versa.
They run together all the time. I've even seen articles where they talk about the ankle brachial index, which I think we're going to talk about a little bit later, as a screening test for coronary artery disease. So it's actually not a bad screen. If you have a decreased ankle brachial index, you probably have coronary artery disease as well.
What symptoms would people experience that would suggest that they have peripheral vascular disease?
The most common presenting symptom for most of the people with lower extremity peripheral vascular disease is claudication or cramping in the legs when they walk. And it's usually a fairly definable thing. Again, on flat ground with standard conditions, more or less, the patient will reproducibly get cramps in his leg muscles at a certain point. They can often tell you half a block and a half, 2 blocks, whatever. And it comes on, wait a few minutes, it just cramps up the calf. They have to stop. The calf is the most common. They have to stop. Within a few minutes, the circulation sort of catches up, and you can walk again for approximately the same distance, and then it will cramp up again.
Now, there's a lot of people in this age group, too, have arthritis, and they have a lot of discomfort in their legs. So, again, differentiate for us, because I know from my practice a lot of people confuse those two. How would you differentiate arthritic type complaints in the lower extremities from peripheral vascular disease?
The arthritic type complaints generally start often are present at rest, and generally start as soon as you start walking or as soon as you start moving. The true claudication, the history is the most dramatic thing, is that it's very reproducible at a certain distance. Again, it's just a point where the muscle outstrips its blood supply, and it won't come on until then, and you stop, and again can walk that distance again.
It's like angina of the legs.
Right, it's angina of the legs.
People oftentimes, though, have different symptoms. They might have discomfort in their arch of their foot as opposed to their calves, or their buttocks, you mentioned. Why is that?
That depends primarily on the level of the stenosis, the narrowing, or the occlusion. The people that get thigh and buttock claudication usually have problems up in the abdomen, in the iliacs or the pudendals or branches of the iliac artery, which is the major branch after the aorta. The aorta comes down, the biggest blood vessel in the body, and branches into the 2 iliacs. If you have problems there, you'll typically get symptoms in the thigh and buttocks. If those arteries are open and you have narrowings, the more common narrowing is as you get further on down the leg, usually just above the knee in the superficial femoral or popliteal artery. There you get the more typical calf claudication. When the narrowings are even further on down, you can see people that have pain in the foot and whatnot. Although, again, it's very variable. There are people with iliac occlusions that manifest as calf claudication. It's not a hard and fast rule.
Right.
Yeah, right.
Nothing in medicine
Nothing,
is right.
right.
Now, there are other symptoms other than I mentioned arthritis briefly, just to throw out that example, but there are other medical problems that can masquerade as peripheral artery disease. It's happened to me where I've thought for sure that I had somebody with peripheral artery disease. I sent them to a guy like you, and they come back to me and say, nope, there's nothing wrong with him. It's something else.
Right.
What are the other things that sometimes masquerade?
The other group, and again, I see somebody like this almost every week in the office where you're asked to make this differentiation. The other group is what we generally call the neuromuscular conditions or musculoskeletal problems. So the spinal stenosis is a classic one. Arthritis, which we already talked about, is one. We said spinal stenosis. The other one is lumbar, back disc disease, that sort of thing. Disc entrapments, nerve root kind of problems. Sometimes they can be relatively tricky, especially in terms of the symptoms. What helps a lot now is getting into the physical examination and the laboratory examination usually help you differentiate these.
What do you often find? It's funny because in my questions I left out the physical examination. See, I'm so attuned to getting testing done. I left out the physical exam, which is horrible.
Right.
What do you find at physical exam when you examine such a patient?
Actually, this is one of the areas where physical examination still is useful. I'm with you on a lot of these things. Listening to the chest, I sometimes feel like I'm doing it more for the image than anything.
Right.
After I've got a chest X-ray and a chest CAT scan and everything.
Then you feel better, yeah.
Right, but here, obviously the main physical finding is usually diminished pulses, especially down in the foot. Or if the person has an iliac higher blockage, you can have diminished pulses in the groin or behind the knee.
So you feel behind the knee. Where else do you feel for pulses in the leg?
In the foot, on the dorsum of the foot where your dorsalis pedis, and then right behind the ankle, the medial malleolus, your posterior tibial pulse, and then up in the groin, for the femoral pulses. And right there, you get a lot of information. The other thing is obviously just looking at the leg. In the more severe forms of the disease, which we haven't spoken about yet, where you start to have tissue breakdown, that becomes fairly obvious. A black toe or a blue toe, areas where a non-healing wound on the foot, that sort of thing.
Any other less obvious physical findings?
Decreased hair growth. Then with venous disease, a little cousin of what we've been talking about, you start to see stasis changes, edema, swelling or edema, problems like that.
It's funny because oftentimes I always feel people's dorsal pedal and posterior tibial pulses, and a lot of times people say, "How come you always feel in my feet? What are you doing that for?" And that's why I do it. So let's say you have a patient who's come in your office, and you suspect, based on their clinical presentation and their examination, that they have peripheral artery disease. One of the screening tests, as you mentioned, is an ABI, or ankle brachial index. What is that?
It's a very, very simple test. Essentially, it's measuring the blood pressure in the legs. The ABI is the simplest form, where you just put a cuff down by the lower part of the calf, or two cuffs, a cuff on both calves, and then a cuffs on both arms, and just measure the blood pressure in each arm with a Doppler. So it's slightly different than the blood pressure with the stethoscope, but generally correlates fairly well.
What's normal? What's abnormal?
The normal, if the ankle brachial index is for your ankle pressure at rest, should be the same as your arm blood pressure. And it shouldn't, even with exercise, which we sometimes do as a more sophisticated test, shouldn't drop that much and should recover fairly quickly. But basically, the bottom line is an ankle brachial index should be 1. In other words, the ankle blood pressure should be basically equal to your arm blood pressure at rest.
Is that a pretty sensitive test? I mean, is it a valuable test?
It's a very valuable test. I mean, there are certain things that can throw it off, as with all the tests that we do. But in terms of a simple, quick, safe, this one, if you stop, I think there's got to be some patient somewhere in the world that is allergic to the gel that we put on for ultrasound, but I still haven't found them.
Right.
It's the one test that I haven't had like any reaction to ever, so far. And so it's really very, very cheap in terms of that kind of...
And simple to do.
And simple to do, right.
Yeah, I do those now in the office, too, to use for screening. And I read an article recently that actually suggested that in diabetics, they probably should, irregardless of symptoms, that they should have it done on a periodic basis as a screen in all diabetics looking for disease, because, as you said earlier, they're more apt to develop peripheral vascular disease.
Absolutely.
And we don't want to miss those people because they may not have symptoms because of their disease. After the ABI is abnormal, what test might you then do to try and confirm those findings?
Well, basically, it depends on what you're thinking of doing with the patient. A lot of it depends on how severe the symptomatology is, how old the patient is, and really how much it's interfering with the lifestyle. If you're talking about skin breakdown, then you're actually in an area where you're worried about limb loss, well, then you've got to kind of move on. Patients where we're just talking about claudication, you may not have to really do anything immediately after that. If it's just claudication, I'll usually, if they're smokers, I advise them to quit smoking. You can try some of the medications, which we can talk about a little bit. Exercise is tremendous. Even before medications, smoking cessation is obviously number one.
And how successful are you with your recommendation to stop smoking?
No more than anybody else.
Than me?
Right?
Not too often.
Not too often. I don't know what the exact statistics are, but it's low.
I'm waiting for that pill to come out.
Yeah. Even with the pills, when they take the pills, it doesn't completely work.
They still smoke with the pills.
Yeah.
But, so what you're saying to me, which I'm glad to hear, is that just because you have somebody who has an abnormal ABI and symptomatology, then you're not necessarily rushing off to do an intervention or a surgical procedure, that there's still some other things that can be done, and the patient can actually have a role in the treatment. I mean, they can obviously slow down the progression of their disease if they stop smoking or if they get their cholesterols down and they exercise.
Absolutely.
Again, another frustrating area for me. How often do people exercise when you tell them to?
In the peripheral vascular, I think it's probably better than cardiac, frankly, because the exercise is simply walking.
Right.
And often is in cardiac too, but that's what I try to do. People can actually increase their walking distance 100%, or in other words, if they can walk 1 block, you can, with training, get them to walk 2 blocks. And a lot of people, that's the critical difference between having a decent lifestyle and being it's amazing in our society. It's not that often that necessary to walk more than 2 blocks.
Right. Right.
Most of the people complain when they go to the malls or something like that and they get a parking spot far away. That's about a lot of people. That's about the only time they walk more than 2 blocks.
Right. Okay, we're going to break here for the break, and we'll be right back. Welcome back. We're here on Medically Speaking. This is Dr. Boris. We're interviewing Dr. Charles Antinori, who is a general thoracic and vascular surgeon. And we're talking today about peripheral vascular disease. Charlie, we got into all the diagnosis and the inexpensive testing, the ABI. Let's talk about Doppler. What does Doppler do for you as far as helping you with this disease process?
Well, the Doppler is used to get the ABI. Number one, that's usually the method that we listen to the blood pressure with when we do ankle brachial disease. But also they have 2-dimensional Doppler, which can be done to get more analysis of the anatomy and can actually predict more accurately where the actual levels of occlusion are. It's also great if you go from Doppler to ultrasound. Is a great way to follow aneurysms. The peripheral vascular, it's great for popliteal aneurysms. It can define popliteal aneurysms, tell you how big they are.
And those are aneurysms behind the knee.
No, aneurysms behind the knee, which are a very serious problem. And this is a nice, easy, again, completely non-invasive way of really defining that to where you generally don't need another study.
Those are another cause of leg pain, correct?
Right. That's
but
right,
that pain is characteristic. How is it characteristic?
Well, they're not that common. I didn't want to mention too much to confuse things, but it's an aneurysm just like in the aorta that occurs behind the knee, and they can cause discomfort locally as they get larger and get confused with orthopedic conditions in the knee.
So it's more primarily right there in the knee.
Right behind the knee joint.
Not going to be in the calf like we were talking.
Well, they can cause, but they can cause serious problems with the calf because they do 3 bad things. They break off emboli, very common. Where some of the debris within the lumen starts to shower down to the feet and get suddenly a toe will go black or something like that. They also can sometimes occlude and they can rupture. So they're a serious problem when they get larger. They need to be taken care of. So
if we do a Doppler ultrasound and an ABI, and they both suggest that you have significant disease and the patient is limited enough that you feel you need to do something else. What's the next procedure that you might take or a test you might do or treatment you might render then at that point?
Well, again, if we're in a ballpark where we think the symptoms are serious enough that we have to do something, the next test, generally speaking, is an arteriogram.
And that entails what?
And entails an outpatient procedure done by Dr. Patel or an interventional radiologist like Dr. Patel at a hospital, generally speaking. But it is usually outpatient. The procedure itself takes about 20 minutes. You naturally have to be there an hour or so before, and they hold your groin for a couple hours after, so it's a half a day sort of thing. But you go in, they'll put you in the X-ray suite, prep the groin, generally speaking, and put in a tiny catheter into the groin, and then inject contrast into the arteries. In this case, it would generally be into the aorta, and just take pictures of the arteries as the contrast or dye flows through them.
Now we have so many new non-invasive procedures, particularly like the MRA or the CT angiogram. Are those of any value here or no?
They're, I think, going to be of tremendous value, but at the moment, the arteriogram is still the gold standard. Speaking today in March 2004,
right.
I think you still have to, before I operate, in general, I prefer to have an arteriogram. If the patient's renal function is compromised, have the high creatinine or something
kidneys,
like that,
yeah.
kidney function is compromised. That's one bad side effect of the contrast from the arteriogram is that it does damage the kidneys. In normal kidneys, it's rarely a problem, but if people already have some degree of impairment it can cause further impairment. So in that group, we look to some of these other imaging modalities, and sometimes you'll operate based on MRA or CT angio. From what I read, tremendous promise for both of these tests. Right now, they seem to be touting the CT angio more as the CT scanners get faster and everything. They think there's going to be a lot more promise with the CT angio in the future.
Now, we did a previous show with Dr. Patel about angioplasty, so I'm not going to ask you about angioplasty today. I'm going to ask you about what you do in that surgery.
Right.
Tell me about when you consider doing surgery for peripheral vascular disease, and what exactly is it that you do?
Yeah. Again, it comes down to when the symptoms are significant in significantly impairing the patient's lifestyle. Obviously, the main time you do surgery is for sure is when you're looking at a limb loss or a limb salvage situation. And generally, what I would do would be some type of bypass operation. Basically, it's simple plumbing, simple hydraulics. We run blood from above where it's blocked to below where it's blocked using either natural conduits like the saphenous vein when we can, or artificial conduits like Gore-Tex or Dacron when saphenous vein is not available.
Saphenous vein is one of the veins in the legs?
One of the veins. It's the long vein that runs up the middle aspect of the leg.
Now, how can you take that out and use it? How does the patient get along without that?
Most patients, if you take a large section of saphenous vein, they'll have some leg swelling for a month or 2 or 3. But fortunately, there's a lot of duplication in the venous circulation of the leg. And the deep system is actually the more important of the two systems. So you just have to make sure the deep system is all right before you go harvesting the saphenous vein. But if the deep system is open, there's very little problem with borrowing the saphenous vein for another location.
Now, you use the term limb salvage, and I just want to make sure that listeners know what you mean by that. Explain what you mean by that.
This is a situation where, generally speaking, starting to get ulcerations in the foot, toes are turning blue or black, and if something isn't done, you'll be looking at an amputation within a few months, something like that.
And so, vascular bypass can oftentimes help that.
Definitely. If you have the proper anatomy, you need, as I say, you need a blockage that can be bypassed, and you also need runoff.
What's that mean?
Downstream, where we're going to plug after. Very often, you bypass one major blockage, but then there has to be blood vessels that are going to carry the blood the rest of the way down to the foot or whatever. And in many people, particularly diabetics, it's a problem because they have disease in the smaller vessels of their leg. And once you get beyond a certain degree of small vessels, you really can't bypass it.
It's too small.
It gets too small, the grafts don't stay open, and that's a problem.
Now, there's some medicines that have come out over the past couple of years that have probably helped you, and I guess helped you in a way because they helped the patient, but they've probably prevented people from needing surgery.
Right. Yeah, right.
So tell me about what medicines that you might recommend in people for peripheral vascular disease.
Well, the old standby is aspirin, which has just been a tremendous medication. The only question I always have about aspirin is, like, if it's so good, why didn't God put it in our circulation to start with? But
along with chlorine, why don't we have it in the water?
Right, with the chloride, exactly. But aspirin is number one. There's numerous studies showing that it improves peripheral vascular, a little bit of improvement in claudication and symptoms and that sort of thing. The new one, Plavix, to me, I'm not totally sold on that. And again, as a surgeon, I have some reservations about it because it works too good. It really does increase bleeding. So when we do have to operate on people, the Plavix is the problem. But it's another antiplatelet agent that's helped tremendously in all areas of peripheral vascular disease. There was Trental and Platel are the other two drugs that are used. There was just a medical letter article talking about the Platel. Trental I was never a big fan of.
I never saw much success.
Yeah, I used it in desperate situations occasionally, but I really wouldn't use it at all now. The drug that's out now, Platel, is a much better agent at doing the same thing. This has been proven to increase claudication distance. Again, as a surgeon, I would prefer to do, if there is a bypass or something I can do, I'd rather do that. But again, we are seeing a lot of really elderly patients, and their surgery clearly carries some risk. So in these patients, if you can improve their claudication distance with a drug like Platel, it can often be all the therapy they need.
But as always, I mean, there's problems with the medicines too, and you have to make sure that there's no contraindications or side effects of the medicines, because a lot of these patients are already on maybe 5 or 6 other medications for other things.
And again, the heart platelet, the one problem is that there's a little bit of a warning in patients that have had congestive heart failure. And again, in this elderly population, a fair number that have peripheral vascular disease have cardiac problems. So that's limited the use of it a little bit.
Very good. That was a very thoughtful discussion. I appreciate it. This is Dr. Boris on Medically Speaking. That was Dr. Charles Antinori on Medically Speaking. Have a great day.